My name is Dweety Modi, and I'm a PGY1 pharmacy resident at TriStar Skyline Medical Center. Today I will be presenting my research on interrupted time series analysis on the impact and durability of Aztreonam criteria of use restriction with audit and feedback at a non-teaching hospital. My co-investigators and I have nothing to disclose in regards to this presentation today. There are two core strategies recommended for antimicrobial stewardship programs, which are pre-authorization and prospective audit and feedback. Recommendations are implementation of some core strategies for the success of any antimicrobial stewardship program and should often be catered based on a hospital's infrastructure, resources available, and the urgency for a specific need. The core strategies can be classified as either restrictive or enabling. A restrictive strategy, such as prior authorization, requires an approval prior to dispensing, but has shown to have immediate positive outcomes. On the contrary, an enabling strategy provides guidance on the front end and reviews the prescribing on the back end. The impact of this on the long run is similar to that of a restrictive strategy. Both restrictive and enabling strategies have their strengths and weaknesses. A restrictive strategy can lead to significant delay in therapy and a lack of alliance but decreases the cost and consumption in real time. This compared to an enabling strategy, which maintains the prescriber autonomy and confidence, is labor-intensive. The short-term impact of restrictive strategy are more pronounced, but the long-term impact of both strategies are similar. The question then remains, are either of these two strategies too restrictive or too enabling? These strategies are actually not mutually exclusive. So in a Cochrane review in 2017, a meta-analysis was carried out and results indicated that enablement consistently enhanced the effects of restrictive strategies. With enabling strategies, there is always the concern that initial favorable outcomes will eventually regress back to prior usage over time, and studies often do not persist long enough to account for this effect, or to determine the impacts on more long-term endpoints such as antibiotic susceptibilities. A criteria of use restriction is a potential strategy to combine both core strategies. We implemented a criteria of use restriction at Skyline in October of 2011, which generally restricted the use of Aztreonam. The restriction did not prohibit or limit who can prescribe Aztreonam, but did provide pharmacists with authority to review and deny continuation based on the criteria. Aztreonam is a monobactam that is distinguished from other beta-lactams by a lack of cross-sensitivity with penicillin allergies and was our drug of choice. The restriction entailed careful assessment of nature and severity of penicillin allergies as well as history of use of alternative beta-lactams and specifically recommended against the common practice at Skyline of combining Aztreonam with other beta-lactams. Our hospital is a 279-bed hospital with 59 adult ICU beds, and we are located in Nashville, Tennessee. We're also a non-teaching hospital with infectious disease coverage only for daytime. The purpose of our study was then to assess the impact and durability of criteria of use restriction along with prospective audit and feedback on the consumption and resistance rates of Aztreonam at a smaller and non-teaching hospital. Our primary endpoint is to look at the Aztreonam quarterly defined daily doses per 1,000 adjusted patient days pre- and post-intervention. We also assessed a few secondary endpoints, including looking at our annual Aztreonam Pseudomonas susceptibility rates, consumption and susceptibility rates to alternative anti-pseudomonal beta-lactams, and adherence by prescribers to the criteria of use restriction. Our study was a retrospective interrupted time series analysis approved by IRB. The patients were analyzed in two groups. The pre-intervention group was from January of 2010 to September of 2011, and the post-intervention group was from November of 2011 to September of 2019. Patients who were 18 years or older and received at least one dose of Aztreonam were included. The model here depicts an interrupted time series analysis. The intervention occurred in October of 2011 as depicted by the X. 344 patients were included in the pre-intervention group and 766 patients were included in the post-intervention group. Each O represents a time period of 1 quarter in each group. Moving on to the result, depicted here is our Aztreonam use in each quarter prior to the criteria. And as you can see, there was a significant increasing trend of 1.54 defined daily doses per 1,000 adjusted patient days. So the trend here would suggest that the need was urgent and would warrant an intervention with a restrictive component. Depicted here is our Aztreonam use post-intervention, and as you can tell, there was a significant decrease in trend of Aztreonam use of 0.43 defined daily doses per 1,000 adjusted patient days. So to put this all together, the graph here shows data pre-intervention in red and post-intervention in blue. As we can see with the criteria implementation, there is a statistically significant change in trend of 1.97 defined daily doses per 1,000 adjusted patient days. Also note here, by the end of the third quarter, when we implemented the criteria, we were using about 20 defined daily doses. But in the fourth quarter of 2011, which was after the implementation of the criteria, the usage was 15.22 defined daily doses, which was a significant decrease. As we can see, there was an immediate response upon intervention, which is consistent with an effective restrictive measure, although potentially more modest than some total restrictive interventions, but the trend was also sustained over a prolonged period of time, which is more consistent with effective persuasive strategies, and it is noteworthy that this trend continued over many years. As you can see, in our last analyzed quarter, the third quarter of 2019, the usage was 0.26 defined daily doses per 1,000 adjusted patient days. This is a dramatic decrease, and more consistent with an enablement component. Also important from a stewardship standpoint is what were the impacts on the susceptibility. As seen here, the Pseudomonas susceptibility rates in 2011 were 76%, which trended up to 84% by 2018, which is a significant gain in susceptibility. A valid question to then consider is the impact on alternative agents. Depicted here is the first quarter data for other anti-pseudomonal beta-lactams. There is an initial increase in carbapenem on the front end as depicted by the green bar, but as the Aztreonam use continued to decline, we do not see a continued increase in alternative agents, and the carbapenem use declined over years. Likewise, the impact was not deleterious on susceptibility rates. So in conclusion, a criteria of use restriction was an effective intervention for decreasing consumption in our hospital setting. So the self-assessment question is, does an intervention such as criteria of use restriction lead to any significant changes in antimicrobial consumption and resistance rates on antibiogram at a smaller non-teaching hospital? And the answer is yes, it does. I would also like to extend a special thank you to my statistician, Laurel Goldine, who has helped me with this project. Here's my contact information and the references. Thank you so much.